with a few cases just to trigger your thinking, and maybe most of you will have similar cases in practice. So you have a 6-week-old female brought to the emergency with fever, septic workup was done as the age, found to have E. coli UTI. And so how would you manage this child? What would your workup plan for this child, and then what would you tell the parents of what to expect in the future? Second case, 7-year-old male brought to emergency with right loin pain, hematuria, found to have Pseudomonas UTI, so more specific symptoms. Again, same questions. How would you manage this child? The age, the gender, the symptoms, would it make different of what to do next, either short-term or long-term? Third case, 10-year-old female brought to ER with fever, hematuria, found to have E. coli UTI, so more typical organism. Mom is telling you this is the 5th UTI in the last 2 years. Before that, she was well. So again, how would you manage this child? How this one is different from the previous 2? Fourth case, 9-year-old male on routine investigation. For some reason, his physician asked for, some orders will come like a setup, urine routine, but then culture came out, and then the culture showed E. coli bacteriuria. Urine routine was negative. How would you manage this child? Would you label as UTI? Would you not? Would you treat? Would you not? What you do next? So the objective of my talk will be management and follow-up of the patient with UTI, and then what investigation would you do, including the renal imaging, because in some recommendation, I would say they kind of overlooked it, and some of them will over-investigate. So where we find the correct way in between. So first of all, you have to make sure of the diagnosis. So history is a very important part, and we will come what's very vital in the history to know. Also examining the child. And unfortunately, now a lot of people, I would say a lot, but there's some number of physicians who don't touch the children and examine them and rely only on investigation, which should not be happening. So you need to know in the history, is it really a UTI or not? Is it just labeled as a positive culture, or is it a urine routine labeled the child as a UTI or not? So first, define what's urine infection. Make sure that there is a urine infection. What was the method of the urine collection? What was the symptom associated with it? How frequent did it happen? What treatment child got? What culture you got? Putting all those together, then it will tell you what's next. You can't move further unless you know definite those information. And then if there's any previous investigation, so if I have a child who's 1-year-old coming with a recurrent infection, did an ultrasound, showed some hydronephrosis, it's most likely reflux unless proven otherwise, right? So guiding you with the previous investigation, some patient would come with it, some not. Majority of patients coming to me as a referral will have, but you as a pediatrician might not have that information. So it's even more important to know what to do next. History, there is a long list of things you need to focus in the history. I will not go through every single one. I'm more than happy to share my slides as a PDF for the audience. So it will be a reference for you of what to look for. But there is red flags. So if a patient, the common things you need to focus on, things leading to this thing, the dysfunctional elimination syndrome. In those kids, they have usually a constipation. They usually tend to hold their bladder. They don't pass urine as frequent, so they might pass like twice a day. So usually less than 4 times a day. And in children, this is not normal. So infrequent voiding, the child, sometimes they hold their urine for a long time, and they have mother would tell you, I would find drops of urine on the underwear, especially when they are so occupied and playing and so on. So this is a big risk factor for children to develop urinary tract infection, and usually behavioral management for those kids will, plus treating the constipation if it was there, will definitely remove the chances of UTI. And this, we see it more in adolescents and teenagers. And there is a big association between it and the urinary tract infection, both in girls and in boys. Examination, so the history done, examination. If you find a child with enlarged bladder, with abdominal mass, evidence of spinal lesion, poor growth of the child, high blood pressure, this is not a straightforward urinary tract infection. There is something fishy there, so you need to dig more for those patients. Those patients will definitely require a renal profile blood test done, an ultrasound at least to start with, plus minus referring to nephrology. It depends on your finding. So determining the location is always a question of, is it upper, is it lower urinary tract infection? The younger the child, it's more difficult to define, as you know. So the more systemic examination or finding, either in the history or the clinical examination, the more it's telling you it's an upper more than lower. But it's not always an easy to label the kids when they are young. When they are older, then it might be more, because then your symptoms will be more specific. And you will be able to tell if it is cystitis or not, because that will make a difference on what to do next in regards of what to treat, for how long, what choices of antibiotic you would pick, for how long should I treat, should I worry about this child in the future, or should I just stop there? Asking about the method of urine collection, I mentioned it before, it's very important. Again, I stress on it because a lot of pediatricians in the outpatient practice, they hesitate to do urine catheter or to do a suprapubic. So they tend to do urine bags. And urine bags almost always positive, right? Especially in a female. Good luck in an infant female with a urine bag. So then you are put in a dilemma. Is it a urine infection? Is it not? Unfortunately, a lot of labs, when they have more than one organism reported in the culture, they will tell you most likely contamination. But that's not true. You still can have urine infection with multiple organisms, unlikely. But then they might even not give you what cultures are there, and microorganism, and what sensitivity. Then you are even more stuck. So start right. Then what decision you will make later on will be more on a solid base. So there is several guidelines of what to do with those children. I find nice guidelines, British guidelines, are the most clear guidelines, because it outline for you age-wise, symptomatic-wise, organism-wise, history-wise. It includes a lot of factors which we talked about on what to do next. It guides you more clearly of what to do next, because we know these cases are very individualized, and you can't put one guideline for everybody below 3 months of age, right? They're different, either in their history, in the organism they have, the recurrency of urinary tract infection, and the finding on the initial ultrasound if it was done. So by rule, anyone below 3 months, risk of urosepsis is there, right? Or risk of sepsis overall is there. So you need to be more careful. And those kids, most likely, they come with fever. That's it. And then you do their septic workup. Part of it is urine. Again, remember, the method of collection of urine is vital, because those children usually are sick and you are rushing to start antibiotic. And if you start antibiotic without taking the proper urine sample, you will be stuck in between. Was it really a UTI? Was it something else? Should I proceed with LP for those patients? You know, I'm sure when I'm talking to you, all the flashback of different patients can come back to you. So below 3 months of age, remember to take a proper sample of the urine to be able to say, was it a urosepsis? Was it a urine infection? Was it sepsis but not due to urine infection? Older kids below 3 months of age, you are more relaxed. The older they get, as I said, they will be more symptomatic. Then you don't need to rush. Again, it depends how systematically the patient looks. Does the patient look septic, febrile, having any specific symptoms, foul smelling urine, mother feel that child is having tummy pain, no other focus of fever, then you would proceed to do at least a urine analysis, do empirical antibiotic, wait for your culture, bring the patient back in a couple of days. Or just proceed with admitting the patient if the patient was requiring IV hydration would help those patients. And in the method of collection, again, it's recommended that when you do the collection, most people, and I would encourage people who don't have it, to have a urine dipstick. In the urine dipstick, you have the leukocyte esterase and the nitrate. Those two, if they are both positive in a symptomatic child with at least fever, with no other clear focus for the fever, it's UTI unless proven otherwise. So having a bedside urine dipstick will help you a lot to differentiate. And instead of sending it away to the lab, take at least a couple of hours to come back, or even longer. It depends on where you practice. So having a urine dipstick, and I'll show in a minute how it looks, it's very important for you. So remember, the leukocyte esterase will be reflecting that there is white blood cell in the urine. The nitrate will reflect that there is bacteria in the urine. Okay? Having all together those four will tell you more it's a urinary tract infection. So the normal urine analysis, and this is the dipstick, and there's two you need to focus on. The third one, the leukocyte esterase, and then the nitrate, the fifth one. Okay, so and it's easy to identify by colors. That will be very helpful for you at the bedside and in your office practice. Urine culture, again, goes what number is significant. So the more clean, let's say, the method of collection of the urine, the less number to be expected to label the child urinary tract infection. So the traditional 10 to the power 5 thing goes with the clean catch. If a child is toilet trained, we can do that. And if the child is not toilet trained, we always encourage to do in and out catheter. If it is in and out catheter, then more than the 10 to the power 4. If it is a suprapubic, which is even more clean way, more than 10 to the power 3. So again, the more clean the way you do it, the more significant. And having a single organism does reflect more truly a urinary tract infection, but remember, you still can have more than one organism, especially if this child has an underlying urological structural abnormality in their urinary tract. Asymptomatic bacteriuria, remember when they sampled the child who had a urine culture and it was positive. So again, if the child was never symptomatic, urine routine was negative, this is not a UTI, it's asymptomatic bacteriuria, and it does not require treatment. It's more common in girls, but we do see it in boys, and you do not need to label the child as UTI or to treat, or to do even a follow-up urine culture. Management, hospitalization, obviously, if the child is sick, regardless of the age, the younger, they are more inclined to admit those kids. But again, if they are even older, like a teenager with a clear picture of pyelonephritis, we would recommend, because we know hydration and starting IV antibiotics is part of the treatment. Antibiotic choices, again, it depends on the age, okay, and how sick is the child. And if you have a previous culture, is it the first UTI ever? Is it a repeated infection? You know that the child was on prophylactic, for example, a BUV children, being on prophylactic antibiotic coming with UTI and a pyelonephritis picture, those patients will be more inclined to admit them and start more broad antibiotic. And I'll show in a table of what choices you would do. In a couple of slides. The treatment duration, that's always again the question. If you have cystitis, the traditional is 5 days, oral antibiotic, and child will be usually well. If it is more likely of an upper urinary tract infection, then you would be more inclined to give a longer duration. We would say a minimum of 7 days. People compare between 7, 10 days, or 2 weeks. There's no big difference between 10 days to 4 weeks, but there is a difference, some statistical difference between 7 to 10 days. So we go, or how sick of the child, I would say a total treatment of 10 days will be reasonable for children, including what was given as an IV. You continue your IV antibiotic if the child is at least 24 hours, better 48 hours afebrile, and then you can get your cultures back, you will see your sensitivity, and then you can easily switch to oral. Or need to keep the patient admitted if it was ESBL. And myself, and I'm sure majority of you see that we have a lot of increasing incidence of ESBL, unfortunately, in the community. Antibiotic, again, this is kind of a guidelines of what to start, the doses and all. Be careful when you go with the aminoglycosides, especially with children with pre-existing renal impairment. Try to avoid them. Cystitis, we talked about. Again, this reference is there, but as I said, I'm happy to share the slides. I want to just go to the big debate on antibiotic prophylaxis. When should we start prophylaxis? People used to, any infant coming with UTI first, to give prophylaxis. But it's not recommended to do that for every single child. we will come later on the findings. So when you have a child, let's say take the 3 months child, so below 3 months coming with urinary tract infection, and the child have the typical E. coli UTI, required admission but responded well to treatment. Those patients, by definition, you need to do ultrasound, and we will come to the what to do with those patients for follow-up in a minute. So this patient, if the ultrasound was normal, was the first UTI, straightforward E. coli, respond to antibiotic within 24 hours, was well, and you discharge home, you don't need to rush to put prophylaxis. While if they have the similar child but have hydronephrosis, you are suspecting, or even the ureter was a bit dilated, you are suspecting reflux, those patients are justified to give them prophylaxis antibiotic till you further evaluate them to proceed with the MCEG and so on. But before that, you don't need to put everybody on prophylaxis antibiotic. But if you have atypical organism, or if you have a recurrent urinary tract infection, mean more than 2 pyelonephritis or more than 3 lower urinary tract infection, or atypical organism, which is basically non-E. coli, then you need to find the reason to justify putting those children on prophylaxis. Prophylaxis is more justifiable in children who are not toilet trained. When they are toilet trained and they are even have reflux, grade 1 to 2, no need for prophylactic antibiotic. Because remember, with giving too much antibiotics, we build up the resistance in those microorganisms, can cause urinary tract infection for other kids in the community. I'll go to the, because of the limitation of time, I'll go to the what to do next, okay, the tables. So in the tables, they divide the children below 6 months and then above. So below 6 months, if you have a child, so if you I'll walk you through this table, just to see how things what guidelines would be. That's for further what to do with them. So if you have a child less than 6 months coming with a urinary tract infection, and then those patients, it's recommended to do ultrasound sometime. Okay, not necessarily at the presentation, but at least in the first 6 weeks, need to do an ultrasound. Those patients, if they, so here you have the age, you have what is recommended, an ultrasound, is it acute during the infection, within the 6 weeks, when to do a nuclear scan, and when to do MCEG if required. So if they respond well to treatment within 38 hours, they have the typical organism, a first UTI, and if those children will need an ultrasound. If the ultrasound is abnormal, then you proceed with the MCEG. If the ultrasound is normal, you stop there. Okay? A lot of, unfortunately, people will just rush with doing everything for them, and you should not. So those guidelines telling us to not to over-investigate, but to be aware to pick those cases with a possible having it. Some people would say, no, I would be safe than sorry. But remember, you are exposing kids to radiation, to antibiotic long-term unnecessarily. So if you go older kids now, older kids from 6 months to more than 3 years, to 3 years, those kids you will see more no than yes in this graph. And that means that if the child is responding well to the antibiotic within 48 hours, not a recurrent urinary tract infection, didn't have an atypical UTI, was not having renal impairment, not affection of the renal flow, the organism was E. coli, then you don't need to proceed much with those kids. Okay, you don't even need to do an ultrasound. Okay, you might need to do a nuclear scan later on, but if your ultrasound was not required, definitely you will not proceed to the MCEG. So you need to wait, stop and think, what do I need to do for those kids long term? Do I need to investigate them or just watch? This is again more than 3 years. I'll just move a little bit to the last thing. It's about the reflux. Okay, so people always worry to miss reflux, but unfortunately some people, I still see kids. I've seen last month a one-year-old with a recurrent infection, and she was told by her pediatrician, most likely your child have reflux, but we cannot do MCEG below 1 year of age, and we don't recommend to put prophylaxis. That was shocking for me. Of course, we did MCEG, and it was bilateral reflux, grade 4. But again, Some people will still under investigate, so you have to find a way in the middle. I know it's not easy to tell you one answer will fit all, as I told you at the beginning. So it's case by case, and we are here, I'm here to support each one of you if you have any questions about any of the patient of what to do next with them. We still encourage general pediatrician to keep the UTI kits and to follow them, because I think this is a major part of the practice for general pediatrician. We should not just take it away as nephrologist. And by that I conclude. Sorry, I don't have enough time. I already ran out of time.